what I'll do is actually just talk to you about why I'm very passionate about this particular topic. And to answer the topic, is engineering integral to medicine? I'm going to say absolutely yes, but I'm always assessing my assumptions and my biases. So I'm always happy to hear from everyone in the room to see what they think, to see what the value they feel in this context. So I'll take you back to 2010. In 2010, I was a doctor in training. We call them resident doctors nowadays. And I'm someone that's always willing to learn. I'm not very good at sort of studying so much, but I know that if you put yourself out there, you can learn just by doing. So there was about 30 of us actually. In about 2010, we were all trainees, and there were several trainee directors. And they put us in a room and they said, this is the opening. They said, in order to be a fantastic doctor, in order to be a brilliant physician, you need to appreciate that medicine is an art. And you need to do two things fantastically well. Number one, you have to know how to take a history. So that's learning how to talk to your patients, ask them their symptoms, their past medical history, the medication history, so on and so forth. And number two, you need to learn how to physically examine your patients. So take cardiovascular exam accurately, do an accurate neurological exam, GI exam, so on and so forth. And then they went on to say that if you are able to take the history accurately and do the physical exam accurately, you will get the diagnosis. And you'll also be able to think of differential diagnoses. And so I was quite drawn into this because I like art. And I thought, okay, it seems fairly straightforward. All I need to do is take history, perform a physical exam, and I will get the diagnosis. And so I put my hand up and I said, can I be that person that sees the most number of patients that comes through admissions? And the other 29, they didn't volunteer, which now I know looking back why. And so I started seeing patients that came in through admissions. So the first person I would see would be someone with a headache. And so I did as I was told. I started taking that history, started undertaking the physical exam, thinking what the diagnosis of the differentials could be. But something bizarre happened at that point. So I was sort of taken to one side, and the senior physician at that time said, Neel, thank you so much for all your hard work. They're all very polite. But actually, what we will do for this patient is we will get a CT scan of their head. If the CT scan is negative, let's get an MRI scan. And let's consider doing an ultrasound scan of the vessels in the neck. So let's go on to the next case. I started writing it down. We have electronic notes nowadays, or paper notes in those days. So I said CT head, MRI head, ultrasound scan of the vessels in the neck. And I thought it was a bit strange, actually, because even though we were told it's an art, the reality of what we were told, what was happening in practice, was slightly different. Then went on to the next case, someone that came in with shortness of breath. So I did, as I was told, take a history, performed the physical exam, and started thinking, what is the diagnosis or the differential diagnosis? But the same thing happened. Neel, thank you so much. And what we will do is let's repeat the chest X-ray. Let's get a CT scan of the chest, keep them on the pulse oximeter port, and if the breathing deteriorates, put them on the ventilator. We've all experienced COVID. We've all been on the front line for the clinicians in the room, and also the engineers as well. Without ventilators, where would we have been during COVID-19? Another example, chest pain. I'll speed up. The plan was always ECG, repeat the ECG, get an echo, ultrasound scan of the heart, get a CT scan of the vessels, and if those vessels are narrowed, let's consider cardiac stents. Someone would come in maybe vomiting blood, plan, endoscopy. Someone would come in with a kidney injury, put them on fluids, but let's consider the dialysis machine. So everyone that's involved in the innovation space, we're constantly observing and constantly questioning. So in my mind, day in, day out, this was happening constantly. I thought there's not much art to this process. Even though we're told to take a history, perform a physical exam, what is actually happening on the shop floor? All I kept seeing was machines. And medicine's an interesting sort of career because it's very hierarchical. And something that I don't like, by the way. But I decided after much observation, I decided to start questioning. So I put my hand up and I said, oh, we were told actually No one else put their hand up. So we were told medicine is an art. All you need to do is take a history, run a physical exam, you will get the diagnosis. So I said, that's not actually happening. And I said that without all this machinery, without engineers, I don't think I can either diagnose or manage a single patient at all. Of course, it didn't go down very well, so I was told that actually engineering has nothing to do with medicine. That medicine is an art. And I was like constantly questioning, this doesn't seem to be true. That if I remove the CT, the echo, the ECG machine, the endoscope, the dialysis machine, the ventilator, I'm pretty confident that I wouldn't be able to successfully manage any patient. And what I kept seeing that was happening, which I thought was even more strange, is that engineers are fantastic at developing devices, diagnostics, and clinicians are fantastic at being trained in how to use the machine. So we get trained to use the endoscope, trained on how to use the ventilator, trained on how to use the dialysis machine, in order to show that we have some form of competency. And the whole thing just didn't make any sense. It seems a very long and burdensome process. And I was wondering, when the machines break, what can we do about it as clinicians? Very little. We have to call up the engineers and come running, and they fix the machine. In my mind, I was seeing a potential problem. So this is 2010. That actually, maybe it makes more sense, instead of engineers doing all this wonderful device and diagnostic development, and clinicians being just told, how to be trained in how to use them, maybe the conversations and devices, diagnostics should be happening from day one. Maybe clinicians, engineers should have those conversations from the get-go, because surely the solution for me would be more effective, more efficient, more relevant. And so I took another risk, which is classic of people in the innovation space. I decided to leave because I was so convinced that there was something in this concept. So I embedded myself in an engineering environment for about 5-6 years. And again, it didn't go down very well, actually. But my portfolio just says resign from training, but I'm still proud of it. So I left. And my aim was to actually just see how we can start having these conversations and just to understand how engineers think, how do they solve problems, and how often are clinicians involved in the discussion. And I can tell you it was a fantastic experience. I can't share with you all that right now, but just being able to be given that chance to have those conversations in whatever field, it could be robotics, microfluidics, which we now know is liquid biopsy, spectroscopy, AI. AI is not new, by the way, so I'm sure you know it's been around for some time. And in 2019, I decided again to approach my mentor. So I returned and I said, there's something in this. I don't know what this something is. I can't show you the metric. I can't prove it. I don't have a device to show you that we're going to take this to market. That wasn't my aim. My aim was just to simply have those discussions and see where those discussions could get us. So I did the same thing. So we should create something together as a community within the NHS to allow clinicians and engineers to have conversations. Again, it didn't go down very well. So at that point, I decided to do it anyway. And we launched in 2019. It's a virtual platform, non-profit. We've got no money to our name. We've not asked for any funds. I don't get paid. But we have a fantastic team that are truly passionate about this. So you can Google search what we do. I tried to experiment with a QR code. It didn't work, so apologies. But it's called the Clinician Engineer Hub. And the aim was very simple, just to connect clinicians and engineers to have those conversations. It's been a lot of hard work, so anyone that knows what sort of being in these kind of startup creative environments is like, it's not easy, it's kind of on our mind all the time. But we do three things fantastically well. We educate, we provide research opportunities and industry opportunities for clinicians and engineers. Just to give you some metrics, because I know it's Cambridge and everyone loves metrics. So from an education perspective, we do face-to-face events. We have talks just like this to get people galvanized and motivated. We've educated well over 100 students face-to-face. We know that students can't attend often in person. And so we have an online educational platform, and our videos have been viewed well over 15,000 times. So we look at this and we say there's something in this, but we don't, again, know what this something could be. research-wise, we don't have any lab space, so we try to be slightly strategic. And since 2019, we've actually developed partnerships with universities internationally. So in the US, Harvard, Stanford. Just 3 weeks ago, we were in New York. New York's a fantastic place. We were at Columbia University. They were opening their doors to just see what we're doing so we can develop a cross exchange with them. We have support from UK universities, Europe, Middle East, Asia. And they donate their lab space because they say, actually, this makes sense. If clinicians come and visit our labs, we get the clinical understanding. And the clinicians are saying, well, we get this engineering sort of exposure. So there's a symbiotic relationship there. We've done this a few times, actually. So we did this with our partner labs in Imperial. We've done this in Cambridge, so Qatar, Imperial, Dubai, Imperial, Singapore, and Cambridge, and we keep doing it because there's certainly something in this. For the academics, we launched a journal. It crashed, by the way, so I'm more than happy to say it was a bit of a disaster. But we did launch, and it was a lot of hard work, so we kind of pivoted away from that. And when it comes to devices and diagnostics, again, it's not a particular focus of mine, it's more of a pathway. I have clinicians who talk about one particular student who's now a doctor. So Jeffrey Turner, he came on one of our programs, and then he entered the lab spaces in Imperial and went on to be part of a team that developed a brace for scoliosis, so a sensor embedded brace to allow, notify people to stand up straight, be cautious of their posture, so on and so forth. So these are the kind of things that can happen just from these conversations. Industry-wise, we have to be perfectly honest. Without industry, I don't think we can advance healthcare. Years ago, it was frowned upon, and doctors jump ship to industry. But the reality is, without industry, we can't do what we do. And so we've had support from Google, Microsoft, NVIDIA, public policy, even the World Health Organization is backing what we do. So there's a lot of potential here. So just to summarize, I would say that the main issue that I see is that engineers are fantastic at developing diagnostics and devices, but maybe they don't have that clinical exposure. I looked into this. When it comes to device and diagnostic development, how often are clinicians involved? And actually, not always. Clinicians are seeing the clinical problem. They know that they want to solve the problem, but then they say, well, how do I contact an engineer, or how do I sort of get this thing moving forward? And so this is where I think the relationship can really improve. I think also, for me, again, probably against the hierarchy, we know that medicine, healthcare can't be delivered without our allied healthcare professionals, our nurses, our occupational therapists, our physiotherapists. And so we are pushing that actually, to be honest, it's taken 6 years to just get to this point. There's a lot of resistance. So we are now pushing that actually we need our nurses to be involved in this process. They're very much clinicians in many ways. They are becoming the specialists. We need our occupational therapists, our physiotherapists. The reality is they're spending more time than the doctors with the patient. And so they also want to do things, but we're not giving them the opportunity to do so, which I think is a bit of a travesty when it comes to the NHS and what they're aiming to achieve. So what I probably would like to just close with is what can we do in Addenbrookes Hospital as a start? What can we do at the University of Cambridge? I think we can do 3 things. We can start loosening the regulation. In the Financial Times several weeks ago, I think Mr. Sinker talked about how regulation is so tight and everyone is fearful of regulation. But actually, we can put out a pilot experiment. We can create a system where engineers sit by the clinicians, the nurses in clinic, day in, day out. Let's give them the chance to do that. Let's invite them on the board rounds instead of just calling them up when the machine is broken. It makes absolutely no sense. And again, I can't prove to you what the outcome would be, but I can say to you that let's just start as a pilot. Because we should start slowly, allow patients, for all patients, by the way, but we should, make sure that patients give that consent to allow that to happen and just see what happens. We can assess over 6 months, 12 months. We've then brought in an engineer to our clinic every day. What's been the outcome? That's one thing. I think one other thing, so I'm probably quite sentimental about this, is that we are losing our own powers. So if you talk to the next generation of doctors that have come through, they are thinking very differently to me. I followed mainly a formal path, but changes sometimes. But if you talk to the next generation, after they graduate, after their first year as a house officer or second year, they're not interested in staying in the system. So when we ask them, always keep asking the question, what's going on? Why do you not want to do what I did? Everyone else did this model. What's happening? They have an immense array of skills. They are absorbing information much faster than I can. They're processing information. They have multiple qualifications already. And you put them in a system that doesn't recognize that. And they go work for startups. They'll create their own startups. They'll develop whatever they like to do because the system is not allowing this. And I think this is a really, quite disappointing. So we have to recognize that the next generation, without them, where would we be as we get older? We need to create new pathways that gives them, protected time, maybe to talk to engineers, develop devices, work on software, whatever they like to do. And so they will be motivated and productive. Just last week at a consultant meeting, one of the sort of headliners was that productivity is at an all-time low. And the reality is, because actually we're not understanding what people want and what they want going forward in terms of their career. And I think it's a very simple thing. We don't need lots of money. We've done this completely with a very frugal concept. And, there's a lot of potential here. So I think also as the final thing, it has to be very multidisciplinary. We started off as, just bringing doctors and engineers together. But the reality is the healthcare system has changed. So our nurses are very much making decisions. Occupational therapists, physiotherapists. And we have to make sure that our teams recognize the diversity of the skill set and make things truly multidisciplinary. Thank you so much.